I am Brian Badman. I'm a board-certified shoulder orthopedic specialist. I am from Indiana. I grew up in South Bend. I root for Notre Dame football. I went to undergraduate education at IU. I don't like winter, so I try to escape to Florida, where I did my orthopedic training for 5 years, and I did 1 year fellowship in Tampa with Dr. Mile, learning sort of the ins and outs of complex shoulder surgery. I knew growing up that I wanted to be a doctor. My mom was chronically ill, so at a young age I sort of realized that I wanted to do something to help people like her out. Through the course of medical school and what have you, I went into some of the different specialties and I fell into orthopedics, just fell in love with it. One of the main reasons I like orthopedics is that there's really an instant gratification for some of the things that we do. When someone comes in and they're broke, if we fix them or fix their bone or do a replacement on them, we pretty much make an instantaneous improvement on their lives. Not only from a pain standpoint, where patients are sometimes miserable, but also from a functional standpoint. My practice is 100% shoulder. I do anywhere from the simple to the complex, from rotator cuff to instability to as complex as shoulder replacement and reverse shoulder replacement. Today we're going to talk about reverse shoulder replacement. Reverse shoulder replacement is a relatively new procedure in the United States. It was cleared by the FDA in 2004. The first reason we were starting to do this were for patients who had big rotator cuff tears with shoulder arthritis. Because of the results and some of the good outcomes we've seen over the past 10 years, we're now treating a lot of different conditions with that type of surgery. So that includes massive rotator cuff tears, fractures, sometimes people with horrible arthritis with bone loss that was a little bit complicated or tricky to do with other standard shoulder replacement. It's really sort of changed the game in terms of how we can manage some of these more complex issues. Rotator cuff arthropathy, or conditions that we treat with reverse shoulder replacement, are generally things that entail something's wrong with your rotator cuff. So the tendons that sort of move the shoulder around have failed. And typically by the time we're talking about reverse shoulder replacement, the simple measures of trying to fix the tendon are not really an option for you. So at that stage, we typically will then talk about more aggressive measures such as shoulder replacement or reverse shoulder replacement in this situation. If you haven't tried things such as an injection or physical therapy and what have you in that regard, there's definitely a lot of wiggle room in terms of trying those measures before you jump into anything aggressive, because obviously you can always shift gears if something's not working, but if an injection and therapy make you better, that's ultimately the best thing for you. Times to then consider shoulder replacement or reverse shoulder replacement, as we're talking about, is really when, as I always say, when the wheels have come off the bus. So when you're miserable, when you literally are changing what you're doing throughout the day because you're worried that your shoulder is going to hurt, those are times where you're experiencing issues with quality of life. When you start giving up the things you enjoy to do, that's the time I think it's really important to consider doing something more aggressive, such as reverse shoulder replacement. We're going to talk about reverse shoulder replacement a little bit from the technical side of things. So the reason we call it a reverse is simply that we're reversing the anatomy of the shoulder. The shoulder is very much in its normal state, like the way God gave us, is a ball and a socket. So it's like a golf ball sitting on a golf tee. So you have a really round ball with a very shallow socket. With a reverse, we flip that arrangement around. So we put the ball where the socket is, and then the ball becomes the new socket. Essentially, we're turning the shoulder into something that's more called a semi-constrained joint. So it becomes more like a hip joint. Where we give it now a smooth surface for other muscles to rotate through. In this particular instance, the big triangular muscle on the outside of your arm, which is called the deltoid, that becomes the muscle that now works to help lift and stabilize your shoulder. So when you then lift your arm up, when the rotator cuff is not there, the deltoid substitutes for that, and it allows you to now elevate your arm and above shoulder height function. Not only does it do that, but it also gives a smooth surface in there again. So if you had arthritis, that new smooth surface takes away the arthritis, it takes away all that grinding, and it helps eliminate a lot of the pain associated with your problem. So now we're going to talk about how do I perform this surgery. So when you come in the OR, you actually will walk you in, we'll set you on a table, we call it a beach chair table. It's probably going to be the most uncomfortable table you ever sat on. We don't want people to stay, so we make it as uncomfortable as possible so that once we're done, you want to get off of it. We have you sitting completely upright, literally like you're in a beach chair. We then clean you up, prep you up, cover it up, and then the incision itself is usually about 4 to 6 inches long. We try to make it right in the crease. We'll open it up, we'll spread down, and then once we're down to the level of the bone, we then have to take down some of the muscles that are still connected, and then that allows me access to open up the shoulder and get exposure. Once we're inside your shoulder, that's when a lot of the fun starts. So we use these tools that look like jigs, sort of like we're doing shop class in the shoulder, and we'll pin those in place, and I'll make a cut. So this is the part where I'm going to make a cut on the humeral head, and we take a little wafer of bone off. And then I remove that's an instrument, and I sort of use a broach to create a little wedge or a mold into the bone, and then again I'm molding it so that it'll hold the parts that we're putting in there. And then I'll take away any residual bone that might pinch or get in the way. This allows you to have better motion. And then we put the trial in. At this point now we're sort of preparing the socket for the ball. So this is a tap. We'll go over the top of the tap and we ream it. We're trying to get some bleeding bone, because the way that this works is that the bone will actually bind to that implant. We'll screw that in place, and then we'll put 4 more screws into that base plate just to give it a little bit stronger fixation. This allows for the implant to be very stable from the get-go, but it also allows for little motion, because that's how the bone will then grow into it. Because ultimately, if the bone does not grow into that, this can fail, which doesn't happen very often. This is now me tapping the ball into place. There's different size balls based on your anatomy, and also to make sure we get the best function as possible. At this point, we're going to trial it, and then now we're gonna put that in. This is this actually video is a little bit older, where we cemented it. Now we don't use cement whatsoever, or very rarely. Once it's in there, we'll now check the motion. We'll reattach any muscles that are still workable or viable, because that's going to give you better stability and better function. At the end of the surgery, we'll close it up. I use a waterproof closure, so there's no stitches to come out. You'll stay in the hospital typically overnight, and I usually will get you home either the next day, or even sometimes nowadays we're doing it the same day. Usually we like to set up a follow-up within about 10 to 14 days of surgery. A lot of that, again, there's no stitches that come out. Purely, I want to have you come in, I want to make sure the incision's healing well, and we're going to get some updated x-rays to make sure what I did at the time of surgery is still consistent with what's going on. Once we verify that everything looks good, the incision looks good, and you're doing well, now I'm going to probably get you set up with physical therapy. And physical therapy, I like to usually start about 3 weeks after surgery. And the reason I do that is that sometimes after surgery or during surgery, I'm able to repair the front rotator cuff tendon. And that tendon, again, I think is very important for function and stability. And so for that reason, I try to slow people down for the first 3 to 4 weeks, primarily to protect that repair. You're going to be feeling a lot better pretty soon from your underlying condition. I mean, your pain's going to be remarkably different. It's going to be better in a lot of the instances, but I don't want you to get too aggressive too soon to jeopardize what we did. So, and that's where I like to get you set up with a very good shoulder therapist. I think they play a very heavy role in your overall recovery. Understand that what you had done is not going to get instantaneously better. You're going to have a little bit of recovery ahead of you. Don't be surprised if it takes up to 12 months to realize the maximum gains and the maximum improvement of what we just did. Rome wasn't built in a day. There's going to be some challenges ahead of you, but my job and our therapist's job is to try to give you the best recovery with the best function with the least amount of complications possible. I will be here along the way. I'm going to guide you along the way, and I'm always one phone call away if there's any kind of issues or concerns.